You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Partridge, Professor of Medicine at Harvard Medical School, Vice Chair of Medical Oncology, Founder and Director of the Program for Young Adults with Breast Cancer, Director of the Adult Cancer Survivorship Program, and Eric P. Weiner, MD Chair in Breast Cancer Research at Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Ann Partridge. Welcome to Season 2 of the Medscape In Discussion podcast series on cancer survivorship. Today, we'll discuss the complex relationship between cancer and accelerated aging. And this includes innovative treatments that empower patients to lead longer, healthier, and more vibrant lives, addressing the unique challenges posed by age and cancer treatment. I think we're going to talk about the fountain of youth today, I hope. But first, let me introduce you to my guest, Dr. Mina Sedrak. Dr. Sedrak serves as an associate professor of medicine and is the director of the Cancer and Aging program at the David Geffen School of Medicine at UCLA. Welcome to the Medscape In Discussion Cancer Survivorship podcast, Mina.
Thank you, Dr. Partridge.
All right, Mina, are we allowed to call each other by first names today?
Yes, absolutely. Yes, that works.
We go way back. All right, so let's go. I'm Ann, you're Mina. I'm excited to have you. And one of the things I like to know before we start and launch into actually what you're focusing on is what got you to focus on cancer and aging? What's your origin story, Mina?
Yeah, so I'm a medical oncologist and I specialize in breast cancer. I see breast cancer patients. Initially, a lot of my work was really focused on older adults with cancer. And I was really trying to understand what is it about older adults and why are they having a very hard time with cancer treatment? And then I realized that it wasn't just a problem of older adults, that the impairments that our patients were having in terms of their physical and cognitive function after their cancer and cancer diagnosis wasn't just a problem of a specific age group, but it extended across multiple age groups. And that a lot of my patients were coming back and saying, I know the cancer is gone. I know you're telling me my mammogram is negative, but I don't feel well. I still don't feel well. I haven't gotten back to my baseline. Now they're starting to develop diabetes and heart disease and osteoporosis. And their medication list grows from, not having many medicines before their diagnosis to a whole host of them. And that really made me think about what are we doing to help our patients feel and recover back to their full health after their breast cancer diagnosis.
All right. So you focus on breast cancer and you focus on the whole patient, which is great. And then the more senior in our communities, which the average age of breast cancer in America is what?
62. The median is 62. Yeah.
So it's a disease of aging, right? I focus on young people, but the majority are going to be older.
That's correct. Aging is the largest single greatest factor for breast cancer. It's actually not just for breast cancer. For the majority of adult cancer, aging is the largest risk factor. And the population is aging too. So we are seeing more and more people living longer. And the number of people who are living past their cancer diagnosis is also increasing because we've done a great job with screening, early detection, and advances in cancer treatment. So even the young patients who are surviving breast cancer, they're now living not just 5, 10, 15, 20 plus years, and they're aging.
Right. Makes sense. And so we need to take care of them and try and prevent their cancers. And also, once they have the cancer, support them and treat well and not cause comorbidities. So tell me about the comorbidity issues. What do cancer treatments, and specifically breast cancer treatments, do to our patients, particularly the older patients, that leads them to be worse off beyond having had a cancer?
If you look at the data, nearly 2/3 of the 19 million cancer survivors, if you looked at all cancer survivors today, have at least one additional chronic health condition. Some of these conditions predate their cancer diagnosis. For example, like older adults, they already have diabetes or heart disease. But a lot of these conditions are then exacerbated by cancer and its treatment. The treatments themselves also alter fundamental biological aging processes that lead to the development of new conditions. For example, chemotherapy like anthracyclines can put patients at risk for developing early onset heart problems. It can also mean that then people who develop these conditions are more likely to have an impairment in their physical function, their cognitive function, and develop geriatric syndromes like frailty. So we know that as a person with cancer who have survived their disease, they are at an increased risk for early onset physiologic frailty and more chronic comorbid conditions.
It's interesting. We talk a lot about frailty per se, and it feels like it's one of those things you know when you see it. But can you give us a little bit more depth on that one? Because I have a feeling most of us, even those of us who care and pay attention to it, don't actually know what that entails in the more formal way.
Frailty is a syndrome, and it's defined as a low physiologic reserve. It's a state in which an individual becomes more susceptible to stressors. They're more vulnerable to stressors. So the classic way that I think about frailty is you have an older person who maybe is in their 80s, and when they fall or have a hip fracture, that is very serious and puts them at risk of potential going to the ICU and even having, death from a hip fracture, which doesn't necessarily happen if you are young, robust, and fit. So basically, it's a way of looking at the whole person and trying to see what our organ function reserves really are. And when our organ function reserves decline, which they normally do with aging, we become more susceptible to having a bad outcome in the context of a stressor like a hip fracture or surgery or chemotherapy. So chemotherapy is a stressor. And what it does is it lowers our physiologic reserves. And that, if it doesn't recover after we're done with chemotherapy, can leave us and leave our patients in a state of frail health. And like you said, it's something that we see that we don't always know how to describe, but you see these even young women who finish chemo, finish their immunotherapy, they're now on endocrine therapy or they're being watched. They look aged. People say you look like you've aged much older. People say, I feel like I'm significantly older than I was. That's because we've really declined their physiologic reserve.
This happens both because they're old and because they need cancer treatment. And there's a lot of things that play into it, right? The comorbidities that they come with,
Right.
the polypharmacy, where they are from an aging and developmental stage. So then how does cancer or cancer treatment itself actually age people? Are there mechanisms that we're aware of? What's happening on a biologic level?
That's really been the focus of my research. I've been really interested in understanding what is about cancer treatment that's driving individuals into developing an accelerated aging state biologically. What we know is that aging in itself is driven by hallmarks or mechanisms that are fundamental processes of aging. These include things like telomeres and epigenetics and cellular senescence and chronic inflammation. And these are normal processes that as we get older and we accumulate more damage, these processes don't work as well to repair damage at the cellular and molecular level. And together, these processes and how they work together control our ability to basically repair damage in the context of damage. And as we get older, that rate of repair declines and the rate of aging accelerates. what happens is when a patient has cancer and is treated with various cancer treatments or cancer therapy, we disrupt these fundamental biological aging processes. A lot of preclinical data and clinical data is showing us that, for example, chemotherapy can induce cellular senescence, which is a state in which the cells stop dividing, they arrest from the G to S phase, and they continue to secrete pro-inflammatory cytokines that lead to a state of chronic inflammation that drives the myelosuppression that we see in patients, the cardiac toxicity, the multimorbidity, and the frailty phenotype. And so in animal models, it's really interesting, they found that when they give the mice doxorubicin, they induce cellular senescence. And then when they give the mice a drug to remove the senescent cells from the tissue, that the senescence not only is removed, but they can able to reverse cardiac dysfunction. They improve physical and grip strengths of the mice. They improve running speed. They improve frailty phenotype. And so it becomes this important opportunity for us to think about diving deeper into the biology, and could we develop interventions that target these pathways to help rejuvenate and improve the physiologic reserve that's been acceleratingly negatively affected by the cancer treatments for our patients.
Okay, so Mina, what I think I heard you say was we found the fountain of youth for the mice. There is a drug we can give the mice that reverses aging and the damage done from adriamycin. So what is that drug? And is there a people version, or what is the mechanism of the reversal?
There are a lot of things that are being worked out. What works in mice doesn't always work in humans, as you know. So senescence is a key pathway that is being looked at in the longevity fountain of youth research. And in cancer, we do now have some repurposed agents that we are starting to test in clinical trials, including some of the studies that we have here, in combination with behavioral intervention like exercise. So we have an ongoing trial looking at women who've received neo or adjuvant chemotherapy, primarily anthracycline-based, but also taxanes, because we have data that taxanes also induce senescence, and randomizing them to getting exercise plus a senolytic versus exercise alone versus a senolytic alone versus a placebo. This is a large NIH-funded multi-center trial in which we are really trying to understand how much can these agents really improve physical function. The primary endpoint is the 6-minute walk distance, which is the ability of a person to walk for 6 minutes, which correlates really well with VO2 peak, which is a key measure of physiologic reserve, an integrative measure of how our lungs work, how our muscles work, how our blood and organ systems all kind of work together in the context of exercise and aerobic capacity. So I don't have an answer for what those drugs are yet, and it probably is going to be more than just drugs alone. Frailty, like I said before, is a multi-system problem, and it would be silly of us to think that we can solve multi-system problems with just one drug, one agent. Maybe that is part of the future. But for right now, I think just like we think about depression as both having a biologic and a psychosocial component, and that the best treatment for depression is to take both medicines that help address the biologic issues, but also to work with therapy to improve the cognitive and psychotherapy approach, that the combination will be really important for treating frailty as well.
Okay, so Mina, no clear drug fountain of youth. We are supposed to exercise anyway. As soon as we finish talking, I'm going to go back and get on my exercise bike or take a walk around the neighborhood, do the things you know that are good for you anyway. And they're certainly cheaper and usually safer than a drug anyway. So we've got this silver tsunami, so to speak, we've got more and more people getting cancer because they don't die young of heart disease or infection anymore in our well-developed societies. Other than exercise, when a person comes along and has cancer, particularly at an older age, do we and should we target particular populations of patients? And are there other things we can recommend in the here and now for our older patients to try and stay as hardy as possible when they're diagnosed and getting through treatment?
When I think about what would help people to try and reduce some of the adverse accelerated aging consequences of cancer treatment, I think about a lot of the things that we have learned from the aging literature, and exercise by far is one. I would just clarify that it's important to tell patients that when we say exercise, we're not just talking about a simple stroll or a walk. It has to actually be moderate to vigorous exercise for about 150 minutes a week. I tell my old patients buying bands, resistant bands, and going on YouTube and doing some of those weight training and resistance training videos. I think that that's really important for us as clinicians to be very clear on what we mean when we say exercise, because exercise for a person might mean so many different things. So I think encouraging people to exercise and to get up and move, even when they don't feel like it, particularly pre, during, and shortly after their chemotherapy or their systemic treatment, is extremely important. There are other areas of people that are looking at intermittent fasting and caloric restriction. There are people that are interested in the GLP-1 agonist and all of those things. There's not enough data on that yet. The only other thing that I would sort of recommend is if the patient has clear risk factors of having a decline, which we now have developed tools like toxicity risk prediction models that we can use to predict the risk of chemotherapy toxicity. If the risk is high, you can consider sending them to a geriatrician and having a geriatrician assess them and do a whole person assessment or a geriatric assessment to then potentially identify what areas of deficits they might have and target that deficit. For example, if they find out that they're falling a lot, we know that if a patient falls more than one time in the last 6 months, that they have almost a 3-fold higher risk of developing grade 3 to 4 chemotherapy toxicity in the neoadjuvant and adjuvant setting if they're over the age of 65. That addressing ways to reduce falling by using physical therapy or occupational therapies, or even just giving them home exercises for strength training, all of that can be done today to reduce some of the harms of cancer treatment in our older patients.
That's great. And where can people find these tools?
So actually, they're on UpToDate. If you go to UpToDate and type in the Cancer and Aging Research Group breast cancer tool, it will be there. They're also online on mycarg, mycarg.org, which is the Cancer and Aging Research Group website. And there's a little tab where you can pull down the tools. You can find everything from the toxicity score that I was just mentioning that predicts the severe toxicities that occur, to a full geriatric assessment, to other smaller geriatric screenings that if you want to use in your clinic to help you learn more about your patient more than the eye can often tell.
So Mina, picture your me, busy breast medical oncologist, Mrs. Jones, 76-year-old, and pretty sprightly coming into the clinic, but I know from experience that I can make her feel like a brisk 85 with the chemotherapy that I need to give her. And we're deciding about that. We're deciding about her endocrine therapy, her surgery, her potential radiation, because otherwise she's pretty healthy, but she's worried too about how this is going to take a toll on her. So tell me, other than going through the side effects, I access the MyCarg website that you just said to go to. Tell me what I do. What's the practical way for those of us in the trenches to do this?
You access the website. There are 8 questions that you fill out, and it gives you a risk prediction for that Mrs. Jones, what the risk of her likelihood of developing grade 3 to 4 toxicity from chemotherapy. You take that information and you think about, all right, this is what I'm faced against here in terms of risk of harm. And then you put that into the context of the potential benefit of the treatment, and you have a frank discussion with her. And if the benefit outweighs the risk, then we continue to monitor her. We encourage exercise. We encourage movement. I often refer these patients to physical therapy early and on during treatment to help them keep moving. And you proceed cycle by cycle, day by day, and you make adjustments as necessary so that you are still trying to provide curative intent therapy without compromising quality of life. It's hard. It's not easy.
I love it. I feel enabled. I feel like it's doable, though. I think there's nothing worse than seeing someone after you've inadvertently hurt them with your treatment, trying to help them, and realizing that they probably couldn't tolerate it and you just weren't working hard enough or thinking hard enough about their vulnerability. So this is very, very, very helpful. And the fact that there are tools with a score that can really help you to drill down to this and come up with okay, here's this other factor of it's going to be harder potentially to get you through this. Is it really, what are the bang for the buck here? Because we know with breast cancer, especially, it's not binary. It's often not life and death. It's risk reduction. And, we don't want to be ageist and undertreat, but we also don't want to overtreat in a setting of high risk. So this is terrific, Mina. Thank you so much. I think that we've hopefully armed our listeners with both the tools and how to think about this increasingly prevalent problem in our clinics as we see more and more people with cancer as they age. Again, this is a good society problem because they're living through, running from the Tyrannosaurus Rex. Obviously, we didn't exist at the same time. But that being said, our world is improving so people can live a long time. But unfortunately, that also means they're going to get more cancers. And so we need to be ready for them and treat and tailor our therapy to this age and end of the age spectrum. Well, this has really been terrific. Thank you, Mina. Today, we've talked with Dr. Mina Sedrak about cancer and aging, and specifically how to detect, measure, and support frailty and prevent frailty for patients in our clinic. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Ann Partridge for the Medscape In Discussion Cancer Survivorship Podcast.
Thanks for listening to Medscape's In Discussion Cancer Survivorship Podcast series with our host, Dr. Ann Partridge. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.